I'm going to start with just three cases here that I'm going to give you, and then turn it over to Holly here for a minute. I'm an emergency physician. One of my roles also is the Muskegon County Medical Control Authority, so we oversee all of EMS in the county, so pre-hospital care. And one of the things we really believe in is that we need to try to get our paramedics involved in the community care, in the home, and that there's so much more that they can do, and that's part of what this is all about. So let's talk about three cases. Let's talk about a 20-year-old female. She's driving. She's not drunk. She's just driving to an event, and a drunk driver runs a red light, hits her car, and she's injured, but not severely injured, but she's injured. She's taken to the hospital. She's evaluated. They do a CAT scan, they do a full workup on her. They find out that she has a bruised spleen. So the spleen is an organ that is quite vascular, but it's not too bad. She didn't break the spleen or anything else. It just damaged a little bit, and she spends a couple days in the hospital. They're just observing her, making sure that everything's okay. She doesn't need surgery, but she's a real fitness person, and she wants to get back to the gym and get back involved in what she normally does. So when she leaves the hospital, she's on some pain medication, and she doesn't really remember everything they said to her as she was going out the door. Now, that never happens, I know. But as we're going out the door of the hospital, she was told what to do and what not to do. And she was told that, you shouldn't do anything that might injure your spleen. But she doesn't quite remember that, and she goes home. So we'll talk about what the community paramedic might be able to do to help with that a little later. Second case is a 60-year-old gentleman who all his life has been getting up on his roof and shoveling off the snow, because that's what he does. He's a very independent sort of person, and he gets up on there and shovels the snow off when it gets too big and too heavy on the house. And he gets up there this time. He shovels off the snow, but this time he slips, falls, lands on a snowbank, bruises his ribs, injures his ankle.
He's going to talk more specifically about that.
And he gets discharged from the emergency department. He didn't have to be admitted to the hospital. They worked on, gave him a full workup. And he's discharged home on pain medication and on crutches. So we'll talk about him a little bit. And when he gets home, he lives in a home that's an older home. And his bedroom's on the second floor, but the bathroom and the kitchen are on the first floor. So we'll talk about what the community paramedic can do to help with that situation. Third case is a 75-year-old lady who developed a blood clot in her leg, and she is treated in the hospital for a couple of days. She's got severe arthritis. She has a number of other medical problems. She's on oxygen because of some COPD and emphysema. So she has mobility problems. But she goes home after a couple days in the hospital, and she's on a medication called Coumadin, which is a blood thinner. Nurses are visiting her, and she's supposed to get her blood checked every week to check her INR, which is the level of the Coumadin level, to make sure it doesn't get out of hand and that everything's okay. She's on a number of medications, and the visiting nurse notices that she's having some more bruising than she should be. This is a few weeks later. She's getting more bruising, and they're a little concerned because she missed her last appointment. She just couldn't get to the hospital. She couldn't get there to get her blood drawn because of all the limitations she's had, and it's snowy out and having some problems. So we're going to talk about those three cases in a few minutes. I'm going to turn it over to Holly.
Thank you. So Dr. Evans has done a really excellent job of demonstrating the types of people and the types of patients that we're seeing transported by the ambulance or coming into our emergency rooms. That's really identifying a need, a gap in service in our community. So the community paramedic program is a new and evolving model of community-based health care in which paramedics function outside of their regular roles. So we kind of know paramedics as the people that scoop us up, put us in the ambulance, and take us to the emergency room. And what community paramedicine says is these paramedics are trained. They can do more than this. We're just not asking them to do it. So how do we bring them into this gap in healthcare services and really kind of utilize the experience and the expertise that they have. So they can use this to more appropriately direct people to appropriate care and to enhance access to care for those medically vulnerable populations. The community paramedic program really addresses specific local problems like Dr. Evans just illustrated, and it takes advantage of the linkages that are developed already within the community to really make a difference. So we can plug in social service agencies, visiting nurses, EMS, primary care providers. All of those links can come together and provide excellent health care for that patient. So we're going to increase patient access to primary and preventative care, provide wellness interventions within the medical home model, decrease emergency department utilization, save healthcare dollars, and most importantly, improve our patient outcomes. So the innovation of the community paramedic program really lays within the enhanced utilization of that existing healthcare resource under the current scope of practice. The program is going to bridge that existing gap in services through coordination and integration of care along with providers, hospitals, home health care agencies. And through this model, we're going to support better health, better care, and lower costs. So a community paramedic can offer a lot of in-home care. These are the types of services that they can provide. They have the training, they have the expertise, and they have the scope of practice to provide multiple primary care services. They also already have experience in taking health care into the home. That's what they do on a regular basis. But the role of the community paramedic, again, extends beyond that traditional role of emergency care and transport with the provision of health education, monitoring interventional services that are directed by that patient's primary care provider. Our community paramedics are already paramedics, they're licensed paramedics, but we're going to give them 80 hours of additional instruction before we even bring them out into the community, and they're going to go through ongoing community education that really is focused on the types of cases that they're seeing in the community. So our goals, these are just so important. We want to improve health outcomes among the medically vulnerable populations and save healthcare dollars. So we're addressing these local community needs and really taking advantage of the collaborations that are already existing between EMS and healthcare and social service providers. And what's important to remember is as the healthcare systems are transitioning towards payment structures that are not going to reimburse hospitals for unplanned readmissions, we really need to get in front of this and find ways to better manage patient health and prevent these unplanned acute healthcare needs and readmissions. So if we can identify the medically vulnerable populations that are at high risk of avoidable ER visits and hospital admissions, we're going to improve the quality of patient care, improve their health outcomes, as well as reducing costs. So these are the impacts that we expect the program. We are looking at the triple aim of decreasing healthcare costs, improving health outcomes, and improving patient experiences. And we're going to look at these in terms of program effectiveness, value, safety, and access. So right off the top, you can see we expect decreased transports, decreased hospital visits, unplanned readmissions, and decreased non-emergent 911 calls. So if we do this right, and I know that we will, we're going to have a huge impact. So we can also look at it in terms of cost savings to the hospital, improved patient safety, and access. We're going to track this information through patient electronic medical records, which are really going to include patient demographics, services requested, the patient diagnosis, referring physicians, time and dates of calls, chief complaints, referral to other services and outcomes. And we're going to use that information to really inform the programming, figure out what our training needs, really dig into what the gaps in services are, and what kind of patients need the most assistance with the community medic program. And this is really just the tip of the iceberg. So Medicare reports that $15 billion is spent in potentially preventable hospital readmissions, and existing community paramedic programs are reporting healthcare cost savings at an average of $10,000 per patient or about $1,000 per patient visit. And we anticipate that we'll have 600 patient visits in year one. So 70% of your hospital readmissions happen within 72 hours of discharge, and that's typically before the patient gets into their first post-discharge primary care specialist visit. So if we can really reach out and identify those patients at high risk, we're going to be able to, again, improve those patient outcomes and make sure that they're not visiting the ER when we could have prevented it. So I'm going to turn this back over to Dr. Evans, who can talk a little more specifically about this.
Sure. All right, so who's going to really be targeted by this? And we're looking at people who have either come into the emergency department or leave the hospital for some other reason. We'd like to start this with our trauma program. We just had our trauma review last week, and the goal is to become a level 2 trauma center. And judging from the way the review went, I think that's going to be given to us, which is wonderful. But what that means is that we're going to have a lot of trauma patients that are going to be evaluated in the hospital, and already are, but then will be discharged home. Those people are multiple injured patients. They have orthopedic injuries, they have soft tissue injuries, they have brain injuries, they have strokes, and they have a lot of different things that occur. And so these are the people we're looking at first. But that's not the only thing. There's people who have heart problems. There's people with high blood pressure, COPD, emphysema. There's people who have minor injuries that were never admitted to the hospital, but they were seen in the emergency department and sent home. These are the people we're looking at. Can we help these people? Then there's the chronically ill patients. The patients with high blood pressure, the patients with renal disease, the patients with cancer, or those that have a number of other medical problems. We'd love to be able to expand that program eventually to take care of all those patients and evaluate those patients. Now, we are not trying to take the place of the visiting nurse. That's not the goal at all. Visiting nurses do an excellent job of seeing patients. But sometimes it takes a few days to get them in. Some patients don't qualify for visiting nurses. And so those are the patients we're looking at. We're filling the gap. We're trying to fill the gap of patients who either don't qualify for the visiting nurse, or who are going to be a few days before they see the visiting nurse, or a few days before they see their primary care provider. There are also a lot of people who are in need of social support in our community. There's a lot of psychiatric problems, there's a lot of dysfunctional families, there's a lot of other things that are out there that we see in the emergency department a lot, and you see in your primary care offices, or we see in a number of areas where these people are vulnerable and we need to help them out. So again, we're trying to fill that gap between hospital discharge and outpatient follow-up. And that can be up to a couple of weeks, and some, especially in our Medicaid clinics, it can be a couple of weeks before you can get an appointment to see these patients. That's a long time after you've left the hospital. Now, in some of the primary care offices, it may be just a few days. But what if it happens on a Friday afternoon, or you're discharged from the hospital on a Thursday and you can't get an appointment until Monday or Tuesday? That's still 4 or 5 days we're talking about there. So, limited or no capacity for short notice medical care visits. That's the other issue. Maybe something's going wrong, and you call your primary care doctor and they say, well, go to the emergency room. It's all we can just tell you right now. There's liability issues if they don't say that, but there's also issues if, but what if they could just call the community paramedic and say, hey, we need you to go stop by so-and-so's house, visit them, see what's going on, evaluate the patient, and give me a call. Okay? So, overuse of the 911 system. In Muskegon County alone, there are 1,200 to 1,300 EMS transports every month. That's a lot of transports from the emergency department, or to the emergency departments. Okay? And that's in a county of 174,000 people. So think about that. That number is quite high. And there's a lot of people that utilize the 911 system for various reasons. Some very legitimate, others because they're confused or they don't know or they're not sure, and others because they're, quote, abusing the system. But actually, that's a small number. There are a lot of people who really do need to use the system because of inability to move. They have limited ability to transport themselves. They don't have transportation. They don't have anybody that can help them into the car. There's a lot of other issues there too. All right, so let's talk about these 3 cases. Let's talk about our 20-year-old in the car accident. Remember, she was in a car accident. She bruised her spleen, but she's a very active person. She wants to get back to the gym. But when she left the hospital, she was overwhelmed. She had just been through a car accident. She'd been through a lot of stress. She was on pain medication, so she wasn't hearing everything that was said to her. So she goes home. And because it's a spleen injury, we are a little concerned, so have a community paramedic go out the next day and visit her. Well, they go out and visit her, and she's planning to go to the gym because she wants to start working out as soon as possible. And the community paramedic has reviewed the discharge instructions and says to her, you know, here's the issue. If you injure your spleen again because you're working out in certain ways, you're going to have a problem. And so they have a chance to review the discharge instructions, go over some of the instructions of what the physician told them when they left. Her appointment isn't for 2 weeks, but if we can prevent her from injuring herself by doing any contact sports or anything more dangerous that might re-injure that spleen, we've prevented a surgery, we've prevented a re-injury of the patient, we've prevented lost work or school time, we've prevented a readmission to the hospital, and we've prevented a problem for this patient by having just one person go visit and say, let's review your instructions. Okay? Let's talk about the guy that was shoveling off his roof. So he's up there shoveling off his roof, he falls, he injures his leg, and he bruises some ribs, nothing he had to be admitted to the hospital for. We sent him home from the emergency department, but we didn't ask him, where's your bedroom? Where's your kitchen? Where's your bathroom? And he gets home, and he's doing exactly what the doctor told him to do. He's taking his pain medication, he's using his crutches, he's keeping his weight off that foot, but he lives in an old house. So he tries to get up the stairs on crutches. How many of you have ever tried to climb the stairs on crutches? At 60 years old, this guy is maybe somewhat overweight, he just can't get up those stairs, and worse yet, coming down the stairs is pretty rough. And what is this guy at potential for? He's at real potential for a fall. If you break your hip, your risk of dying in the next year goes dramatically up. If we can prevent one broken hip because somebody went in the house and looked at the house and said, you know what, this is an issue. We send a community paramedic into the house, the guy's doing exactly what the doctor told him to do, but he's nauseated and a little dizzy from the pain medicine they gave him. They prescribed for him. Well, we didn't know that in the ER because he didn't take it in the ER. He took it when he got home, right? So now he's a little dizzy and nauseated. So if we can say to the community paramedic, he calls the primary care doctor on the phone. The community paramedic says, hey, this is what's going on with your patient. He wasn't going to see that primary care doctor for 4 or 5 days, but now the primary care doctor can get on the phone, arrange with the insurance company to with somebody else to get a bed for the patient in his living room, so he doesn't have to climb the stairs. He's by his kitchen, he's by his bathroom then, and he can change his medication to something that isn't going to cause the nausea and the dizziness. Maybe we've just prevented a broken hip in this guy. Not only does that save money, that's great, but it saves a guy from going through an operation for a broken hip. It saves probably risking his death at a younger age than he would have otherwise. It saves a readmission to the hospital, and it allows this guy to now be able to function in his own home rather than ending up in a nursing home because he broke his hip. This is a dramatic effect on one person's life, but it saves an entire healthcare process that shouldn't have to happen because he just was on crutches and he lives in an old house, right? All right, let's talk about our 75-year-old lady here who has a blood clot in her leg and she's on Coumadin. She's got visiting nurses coming in, but she missed her appointment because she couldn't get to the doctor's or to the lab because it was cold out and wet out, and she has mobility problems anyway. So the visiting nurse goes in and realizes that this patient's bruising a little more. and she's concerned about her. Now, she could draw the blood and send the blood off to the lab, and it might take a day or two to get that back. Then that has to be called to the primary care physician, and the process goes on. It may be a day or two before we find out what the INR was and the need to adjust the medication. Or she could pick up the phone, call the community paramedic. They send out the community paramedic. They do an ISTAT test, which is what we're going to talk about here in a few minutes. And they do right there in the house, they do the test. They determine that her INR is a little high, so they hold her next dose of medication, and they prevent a potentially fatal problem. Because if you bleed in your head or anywhere else, obviously that's going to be a problem. So maybe we've prevented some further problems for this patient. So what are we talking about here? This is what we're talking about. This is an ISTAT analyzer. This device is going to help our community paramedics to be able to do testing, point of care testing, which means in their homes, in the patients' homes, to be able to do these tests on these patients. This includes CBCs, which is the complete blood count. It includes electrolytes, so sodium, potassium, chloride, bicarbs, glucose. It can even do blood gases, which we probably wouldn't do very often in the home, but it could. But a PT-INR, which is what we look for Coumadin, it can do a number of tests depending on which cartridge you get for it. So this device is what we would like to be able to provide to our paramedics. Community paramedics, as we said, are going to have a lot of training, but they would need these devices to be able to utilize and to be able to get the testing done that they can then benefit these patients. It's only a part of what they do. They're not going to test every patient. But this is an important part. And one of the things that we see a lot is patients coming back because a blood test came back normal. Maybe they went to the lab and they had their blood drawn, and the next day their primary care physician gets a report that the potassium was high or the sodium was low. Well, was that a laboratory error or was that real? Or the BUN creatinine, which is the kidney test, were off. Is that a real test or was that a false positive or false negative? If we could send a community paramedic out to the home with this device rather than having the patient come back to the hospital again, get the blood drawn, or come to the ER in the middle of the night and have a reevaluation of everything, could we save not only cost, but save problems for that patient? I think we could. I think we can make a tremendous difference in lives. I think we can make a tremendous difference in people's ability to prevent further injury, prevent further disease, and prevent further problems for these people. What is the cost of this? The cost of the 2 ISTAT machines, and right now we would utilize, because ProMed is owned by the hospital, we would give the 2 ISTAT machines to our ProMed crews, and we would be training those ProMed crews in community paramedic. As we said, 80 hours of extra training in addition to their already community paramedic, their regular paramedic training. We are going to hand select people to be in these positions. And we also want to do this for White Lake, North Ottawa Community, and Oceana, because that's where we send our trauma patients and a lot of our catchment area. But we're specifically asking you to consider looking at a couple of devices for our ProMed crews. Testing cartridges, 3-year supply at about $10 a cartridge. It varies depending on which cartridge you get. But roughly an average of $10 a cartridge is about $9,000 if we do 300 tests a year. So the total requested is about $33,000. I believe that the community paramedic program in general, and this is just a small part of the program, the entire budget for the program we're talking about is about $240,000. We're trying to get several different grants to fund this because right now Medicare and Medicaid do not reimburse for community paramedic services, and that's a problem. But we would like to be able to train our paramedics, give them the resources they need, and utilize their expertise in helping patient care in their homes, in patients' homes, rather than having them have to come back to the hospital all the time. And if we can send those medics in to prevent injury, to prevent problems, I think we're going to make a huge difference in people's care. So our request to you folks, and you've been extremely generous in the past, one of the things that we are still utilizing very heavily is the mannequin that you purchased for the sim lab in the past. That's been a great asset. I'm very grateful for that. We've been utilizing that to train people all over West Michigan, and that's been a great asset. But this request would be to help us get this program started. And we're looking at about $33,000 to get this 2 iStats and the cartridges needed to help us get this program going. So, questions? What can we answer for you?
Are there other successful models of this in other states?
There are. Community paramedicine has been a program that has been probably really kicked off in the last 5 to 6 years. I know that, Holly, you've done some research on which states have it. I think Texas, Oregon, Maine,
North Dakota. Yeah, there's about 6 or 7 states. Currently, there are no functioning community paramedic programs in the state of Michigan.
Yeah, one of the things with the state of Michigan is that we have to get a special project approved by the state from the Office of EMS Trauma and Office of EMS and Trauma. So through the Medical Control Authority, we are currently applying to them for a special project for this. There are a number of programs starting up in the state of Michigan right now that we're trying to get going, and we would be one of those programs.
Do Medicare and Medicaid support these in the states you mentioned?
Some of them are, yes, because they are working on getting this done, and Medicare and Medicaid are looking at these programs very carefully.
And in our state?
In our state, none. No, not right
But in
now.
the other states, they're looking at them, or they're
They are.
researching them?
They are looking at them, and I believe some of them are supported because of special studies through Medicare and Medicaid.
So you can document that you can save the payers some money?
Yes.
Attaboy. Okay. How would you pay for the cartridges after the 3 years?
Well, a couple of things. Number one, we hope, and we believe, I strongly believe, that community paramedicine will be paid for by Medicare, Medicaid, and other insurance companies by that point. I think that this is a up-and-coming model that makes a lot of sense for a lot of programs, and I'm fairly confident that in a 3-year time period, that would progress to that point.
So your aim is actually to be a bridge in between the hospital and when there can be nursing services to
Right.
help to take over.
Nursing services and primary care. We're not looking at long-term care for these patients. We're not looking to do, 5 or 6 weeks of community paramedic care for a patient. What we're looking at is the first 3 to 5 days after they leave the hospital. How can we help prevent further problems in that time period, that gap area?
And how are you going to decide who you see? I mean, a young girl that has a splenectomy that just doesn't know when she goes home her instructions. I mean, nobody knows their instructions when they've gotten pain medicine out of ER and they've been through a trauma situation.
Right.
So how are you going to choose who you send a paramedic out to and who you don't for the next 24 hours?
Yeah, the initial goal here is to work on our trauma program. So what we would start this with is our trauma patients who are discharged from the hospital. Now, this girl that we're talking about would be a level 2 trauma when she came into the emergency department. So we would send our community paramedics out to visit her through the trauma program. Because anybody who comes in as a level 2 trauma or level 1 trauma would then be followed up during our initial phase. Okay, we're talking about the first year. After that, we would love to expand this to stroke patients, to cardiac patients, to a lot of other types of patients throughout as we grow the program and as we develop the program. We have to apply for a special program or special study through the state for the EMS providers to even do this. And that's what we're doing now. And they have approved other programs, or they're working on approving other programs, and it's very sure that they're going to be doing that. In fact, Grand Rapids is starting a program with Life EMS. They're working on that now. And so our program is based on a lot of some of the similar programs that they're working on throughout the state. We're working very collaboratively with a number of agencies throughout the area.
What happens if you don't have primary care? Like 1,000 people that come through there.
Yeah, absolutely.
Where does that go? Where does that filter to?
Yeah, that's a great question. There are a lot of people that come to the emergency department that do not have primary care doctors, or have primary care clinics that they can't be seen in for quite some time. And that's a great question. And the answer to that is tough, because right now we don't have a perfect answer for that situation, because there's not enough primary care in Muskegon County to take care of all the patients. In that case, if the community paramedic can go in, there is going to be oversight of the program through the Muskegon County Medical Control Authority. Will oversee that program. And can we then get that patient to a specialist? Can we get them into primary care? These community paramedics will be trained in what the resources are and collaborating with the hospital to then hopefully get them primary care as soon as possible, especially the ones that really need it. Those patients that are in urgent need of primary care, they go up on the list to get into that queue to get their primary care doctor as soon as possible.
So Jerry, can you explain to me a little bit about the process? So if you're targeting the trauma surgeon or the trauma ER docs
Right.
initially, there's going to be education for them to utilize the resource, I'm assuming.
Right.
But I'm wondering about how the whole system closes. So you have the referral from the ER doc to the paramedics.
Right.
How do the paramedics get access to the medical record? And then secondly, how do the paramedics share that information back to the primary care physicians, patient-centered medical home care manager, and primary
Right.
care doctor?
So a lot of this is going to be, because we're starting with our trauma program, a lot of this is going to be coordinated through our trauma coordinator. And then our trauma coordinator will oversee our trauma patient follow-up. So that currently is Heather Ruffin. And she will then be following up on these patients and be the liaison between the community paramedic and the ED, and she'll be following up on those programs to make sure that the referrals get done, that the follow-up is done. The access to the medical record, again, is because the referral comes from us to the EMS agency. We can then share that medical record with them. And the discharge instructions is primarily what they'll be looking at. And it'll be like any other referral to an agency. It'll be, please go and check on patient safety, check the INR, check the potassium, check the renal functions, or something of that sort. And then also giving them the name and number of the primary care physician to then contact and get follow-up.
So the results of the lab tests will go back to the primary care physician and not back to the trauma center? Right?
Well, actually, the interesting thing is that these devices can be downloaded into the into the EHR, into the electronic health record.
At the trauma center, not at the PCB office?
Right. And we can then, most of the PCB offices have access to the lab tests through the electronic medical records.
So,
Oh, I'm sorry.
I'm sorry. Last question is, what's the accuracy on the test and on the handheld device compared to what internal controls on the blood specimens in the ER?
Yeah, these devices have been used for a long time. These are not new. These have been around for quite some time. And at least from my knowledge of these devices, they are extremely accurate. These are used in emergency departments all over the country. And there's a lot of quality control with that, and there's also quality control with every test. It does the quality check on that.
Are these the same devices that your home care agencies use for proteins and INRs that we send out to our patients' homes like tomorrow when we need a protein and INR?
There is a specific device for INR that's different than the iStat. So I'm not sure which device they're using, but it's not. They're actually home devices now.
They're not going to cross here that home care agency that's coming out tomorrow and the case manager that set up a bed and everything for that patient before I left the emergency room because they knew you had stairs.
Right.
Is there not a case manager in the trauma center that evaluates that patient before they go home
No.
on crutches?
No, there's not. Not for patients discharged directly from the emergency room.
Out of the emergency room, there's no case manager?
Not for something like that. Because we discharge a lot of patients on crutches and a lot of injuries. There's no way that anybody can keep up with all of that. But the patients who are discharged from the hospital for various reasons who stay in the hospital, they will have a case manager evaluation. a patient that's in the hospital, that's there for several days, they might be able to have visiting nurses the next day. That's great. But on a Friday afternoon, we're not going to be able to coordinate visiting nurses out of the emergency department right away, in most cases. Now, that doesn't mean that that can't happen, and the goal is not to replace visiting nurses in any way. This is a complementary program for that and should help fill the gap between the time when the patient goes home to the time that visiting nurses or a more extensive program can be in place for these patients.
Are two of these things going to be enough?
Are two of these enough? That's a good question.
I mean, how are you going to pass them around, you know?
Well, the ambulance is not the one that's going to go in, okay? So we're not sending an ambulance. We don't want one for every ambulance because we have a limited number of community paramedics we're going to have. The goal is to have one or two per shift that's available to go in and evaluate the patient. And if you look at the Muskegon County area, we have two EMS agencies that cover Muskegon County. We have ProMed and White Lake. Both of them are very interested in this program. We also have Oceana County EMS, which covers a lot of our patients because we send a lot of patients from Lakeshore are sent to us as traumas. And then also North Ottawa Community Hospital sends patients to us as traumas. So by using those four agencies, the goal would be to have one for each agency, at least one for each agency, probably two for ProMed because they're the busiest agency that we have.
So when these community paramedics go out to the homes, like on a Saturday,
Yep.
they're going in the ambulance, they're driving their ambulance there, and they're visiting the patient. They're private. They're going privately as a community paramedic.
Well,
privately.
they would not be going, it would not be somebody on shift as a paramedic that would necessarily go out. Where we're looking at is having a community paramedic that would be available to go out to these patients' homes. They would not drive an ambulance there. It's a little
yeah,
disconcerting to have an
Are
ambulance.
they part of the ambulance group, or that day they're on call as a
Right,
community paramedic?
exactly. That day they're on call as a community paramedic. Yeah.
In the EMS agencies, so ProMed, White Lake, and Oceana have dedicated ProMed has dedicated 2 crews, and the others have dedicated 1 crew to community paramedic.
I guess my question is similar to Deb's.